appreciate everybody's time. So as Amelia discussed, we'll talk about forensic social work today, some opportunities and challenges. Hold on just a second here. So most of you have seen the agenda, it was right in the registration. We'll talk about career opportunities, things like working in local jails, prisons, community mental health, contract agencies, police social work, resources for new social workers if they're looking to kind of get into the field. Also, too, we'll talk about some things that work well and don't work well necessarily in forensic settings. So these could be things like confidentiality, building relationships with other professionals, and issues of security and safety. We'll talk about things that are really important for social workers in these types of environments. So that would be different skills, ethics, and responsibilities that are really important in these types of setting, as well as some good areas for therapeutic training and intervention. So I'll give a little bit of a background about me. I am a social worker, but I'm also a human, a mother, a daughter, granddaughter, sister, niece, all of those things. This is a picture of myself and my son, Leto. I have always had a natural curiosity to the criminal justice system, and this stemmed around when I was 6 years old. My father was arrested and eventually incarcerated on multiple charges of aggravated sexual battery. He was a registered sex offender in Virginia since the 1990s, before his death in April of 2023. We didn't have contact throughout my life. Those were always kind of very complicated feelings for me to navigate. But I always felt empathy for him. And working in forensic settings helped me feel a lot spiritually closer to him. And it also helped me with navigating my own grief, to losing my father and also the impact of his incarceration. What I will also say about today is that all aspects of the presentation today are based on my own personal experiences as a clinician and social work professional. Primarily, I've worked and lived in upstate rural New York and Vermont. I'm not speaking on behalf of any other agency or entity today. There may be limitations and other areas of social work within the criminal justice system to which I don't personally have a lot of knowledge. It's really good that we have a wide variety of individuals on the call today, because it can be a really good opportunity for learning. And I think as professionals, we're always learning, growing, and that is perfectly okay. So just a little bit about forensic social work. I won't read the whole quote, but really it is anything related to social work that impacts law, legal systems. So this could be psychiatric hospitalization, for individuals being treated for competency. It could be issues relating to litigation, both criminal and civil. It can be child custody involving separation, divorce, juvenile justice, corrections, and mandated treatment like parole and probation. So various social worker roles, and this list isn't inclusive of all roles, but it's a list of a number of different types of things that social workers can do in the forensic field. So obviously, as mentioned before, they can work within a jail or prison. And this could be via a contract agency within a facility, or a state oversight entity, or the facility itself. Sometimes community mental health clinics also have contracts with local jails and facilities, so that might also be a method and way that individuals are employed within a correctional setting. In addition, community mental health is a great way to get experience with people that have had involvement in the criminal justice system. Oftentimes, you see um, individuals that have a history of parole, probation, are adjusting from incarceration, are mandated to mental health and treatment courts, and also assisted outpatient treatment programs. So, assisted outpatient treatment, we have that in New York State, also know that's in other areas, but that is for court ordered treatment for individuals with typically serious mental illness that pose a risk to themselves or in the community. And oftentimes that involves multiple psychiatric hospitalizations, legal intersecting events, and also non-adherence to medication interventions, which would reduce some of those symptoms. As I said before, this could also include treatment courts, mental health courts, which are typically designed to help individuals with recovery and maintaining outside of incarceration. Um, in addition, juvenile justice, child protective services, working with children in residential settings, and sometimes social workers end up in the area of child custody, divorce mediation, working in lawyers' offices for family court or criminal court related concerns. Um, and then another role, which is also very interesting, is embedded social workers within police departments. So within police departments, I think, one of the things I've seen is definitely the importance of co-response, very like together with the police. I think sometimes I've seen challenges if the response isn't at the same time. And there actually was in June of 2024 a recognized national model of police social work, which was developed in Connecticut. And I'll have some links about that in the future of the presentation. In addition, sometimes in more rural areas, there aren't a large amount of police staffing. So it's not always possible to have an embedded police officer or embedded social worker within a police department. So some ways that rural counties or rural areas manage that is by creating databases or methods of close collaboration so that when a law enforcement professional comes in contact with somebody for a mental health related concern, that they connect that person with a mental health staff within an agency, as well as care coordination programs if an individual is needing support. So there's a lot of reasons why forensic social work are important. Obviously, these are situations that are extremely high stress for individuals involved, as well as their families. Social workers are really great in that they have so many skills, so many positive traits, and our profession is bound by some really good ethics that help to provide people relief as they're going through these types of situations. It's also noted that, there's a lot of statistics here, but there's a high percentage of individuals within jails and within prison settings that have a diagnosed mental health disorder or substance use disorder. In addition, one of the things that also occurs is that sometimes the most vulnerable, so individuals with pretty serious mental illness or just individuals in need of mental health treatment, don't often get the care that they need. So sometimes this looks like they're prescribed mental health medication, but in some capacity, they don't receive that medical intervention. And then there's a high percentage, as you can see here on the chart, that shows that 42% of individuals that are in severe psychological distress within federal prisons have not had mental health treatment. So I want to talk a little bit about mental health policy and how that kind of impacts current systems in mental health. So prior to 1945, those who were designated as having a severe mental illness in the United States were often institutionalized. There was a significant increase in more long-term treatment of these individuals between 1890 and 1940. This resulted in more than half of all hospitalized patients being institutionalized actually for 5 or more years. Many of these individuals were of the aging population. Obviously, back in the 1800s and early 1900s, we thought of mental health very differently. But there became a really high need of growing healthcare needs, and hospitals really couldn't accommodate individuals that were institutionalized. So that resulted in a lot of unhealthy situations, unethical treatment, which became very much criticized later on. In addition, staff working in these roles became really unhappy. They said a lot of times that the roles were more custodial rather than therapeutic, obviously facing workforce issues, even similar to today. And so that led to a lot of reform regarding institutionalization of the mentally ill to shift within the United States. So in 1936, a psychiatrist named Samuel Hamilton, he led efforts in creating a mental health hospital survey committee using staff from the U.S. Public Health Service, the American Psychological Association, and also other organizations. In 1941, there was a survey, and it advocated for more financial support for the hospitals, as well as for more autonomy with psychiatric treatment. The report was pretty sparse in terms of recommendations to address some of the challenges that presented in psychiatric institutions. But it was also clear at that point in time that society's perspectives of the treatment of mental illness began to shift. So it was really during the time of World War II that marked some significant changes in the way that people began to see mental illness and the treatment of mental illness. So some of those changes which came from the war was the idea that increased efficacy in community and outpatient settings, that there was a person and environment approach. Those types of things were starting to be explored. Also, early community identification of mental illness to help reduce hospitalizations was another idea. In addition, there became a large belief that psychiatry could identify and eliminate environmental or social factors impacting mental illnesses. So really, there was a belief in kind of summary that symptoms could be stabilized outside of a hospital setting. And so that enhanced the role of the federal government in implementing policy and community mental health policy. So the National Mental Health Act of 1946, and also the creation of the National Institute of Mental Health, paved the change for that in terms of moving to community mental health treatment. And that eventually led to the development of the Community Mental Health Centers Act of 1963. There were a lot of unintended consequences of that act. Firstly, it lacked clear direction of the functions of community mental health centers, as well as what kind of supportive services or functions would support integrated care for those with serious mental illness. In addition, the policy really considered that people could live with the support of their family, but really didn't consider that individuals with serious mental illness may not really have social supports. In 1960, 48% of the hospitalized population was unmarried, 12% were widowed, and 13% were either divorced or separated. There really was a lack of competency in professionals serving this population. And really, there was a large focus on individuals with lesser acuity in terms of symptoms. So in 1977, there was a report that came from the US Government Accountability Office to Congress that really provided some criticism surrounding deinstitutionalization, including poor integration of care, Medicaid being the primary financial supporter of mental illness, and that agencies were focusing on financial support rather than treatment that led to recovery and independence. So another criticism that also came is that some of the preventive services were not yet proven successful, and that really individuals with SMI were moving towards an area of neglect. So really without housing, nutrition, supervision, daily activities, those with SMI have been more likely to have social challenges, use substances and alcohol, engage in disorderly conduct or petty crime, and become homeless or incarcerated. So as social workers in the forensic settings, we work with people from all walks of life. This could be people with depression, anxiety, trauma, substance use disorder, serious mental illness, psychosis. Really a key skill is engagement with this group of people. It's important to be present. It's important to be authentic, to be consistent, trustworthy, caring, confident. A lot of times people don't know how to trust. They feel a distrust to the whole system. They're going to distrust you. I think it's also important to know that you've made it this far in your career for a purpose, and you have education and you have the skills and oftentimes the experience to navigate these issues. Just remember, you're all professionals. Imposter syndrome is very real, but be confident in your abilities and your intuition as well. So trust your gut when situations don't feel right. A big part of forensic social work is crisis and risk assessment. So really, this comes up in terms of how do we gauge that someone is moving in a direction where they may be at a risk of harm to themselves or others. So suicidal ideation, homicidal ideation, and psychosis, which impacts functioning, caring for oneself, awareness of their self and their surroundings. So some tips in terms of how to assess. One thing is you have to be confident and comfortable about talking about suicide and homicide. So consider a lot of training in this area if it's not something that you have had experience in yet. So these could be things such as mental health first aid, assist, Columbia suicide severity rating scale, touching base with your supervisors, also other colleagues as well. I think when you're doing a thorough risk assessment, you also try to learn about the person, learn about their background, who's in their life, what are their current things that they're experiencing, what's impacting their stress level, how are they eating, how are they sleeping, how frequent are suicidal thoughts, or homicidal thoughts, asking them very, very straightforward. Um, are you going to do something to yourself or someone else if you leave here today? It's important to note too that there are differences between non-suicidal self-injury and suicidality. So non-suicidal self-injury would be self-harm that's not with the intent of suicide. In addition, asking about access to weapons or tools to harm self or others. It's important to pay attention to if there is a history of harm to self or others, and really what happened when those times occurred in the past. Safety planning, using collateral contacts. I think it's also important understanding certain diagnoses that come up and their impact on suicidality. So definitely diagnoses such as BPD tend to come up with a high risk of suicide rate compared to other diagnoses. I think it's important to be comforting, be present, be empathetic. Don't put a silver lining on somebody's situation if it really sucks. Um, Assuring people they're not irredeemable. In a correction setting, you may be talking to somebody that really is struggling facing their crimes and what they have done, letting them know that there's nothing that they can do to be irredeemable as a person. Um, Certainly, there are situations which may trigger more high risk um, to suicide or other violent events. So, this could be any event that involves firearms outside of a correctional setting. Rejections and breakups come up quite frequently. High profile criminal cases and crimes to which people feel a large amount of shame around. It's also really important that um, we're advocating for our clients in forensic settings, um, still have holding them accountable. Obviously, if there are terms that they need to abide by, such as parole or probation, those things are a privilege and alternatives to incarceration. So I think we need to remember to remind our clients of that as well. Um, Psychotherapy, if it's good and beneficial and there's time for it, definitely, as well as care coordination. So there are definitely some key ethics and skills for working in this area. Definitely empathy, respect, dignity, and worth of all human beings. That's pretty paramount to social work, but it's really stands true in this field. People will know and also tell if you're carrying a bias and if you're not kind of checking yourself on those biases. Obviously, in certain settings, in most settings, we need boundaries. In a correctional setting, you may have individuals asking you for things which aren't allowable based upon the facility's requirements. They might be asking for um, something as simple as paper, something as simple as a pencil. Um, they could be asking for advocating around a medication. Those things need to be checked with facility staff to ensure safety. If you're working within correctional settings, you also have to be aware of safety and security. So follow the rules of the facility. Typically, people do not bring items into a correctional facility. I kind of always use the term bring your keys and that's it, and they'll end up in a locker before you go into a secure setting. That's safest, but certainly different facilities have different rules and things that we abide by. Um, I think if you're working in community mental health, definitely be aware if there's certain situations where there's order of protections between clients that are getting services in your clinic. Also, too, be careful if clients ask you things about yourself. That could potentially pose a safety risk. And it's not to say that, um, you know, every person you talk to is a risk to your safety. That's not true. Um, but sometimes that information can be shared around. But also too, with self-disclosure, we're taught in social work that there really needs to be a therapeutic purpose to that self-disclosure. Certainly, there's a lot of problem solving, patience, self-awareness that comes when working in this field. I think also getting help for yourself if you need it or are um, experiencing a kind of high stress event. Time management, sometimes really high caseloads and in all settings. So being able to prioritize clients based on their needs. Um, Definitely documentation is important. Those types of things can show up in court and be subpoenaed, leading to having to testify. Sometimes those things can have an impact on the therapeutic relationship as well. Definitely important to develop relationships with your colleagues in this system. They're also stressed. They're also experiencing workforce shortages. Um, get to know who they are, be a listening ear for them and a support. It makes a huge difference in their day. You also may witness, and they may witness a violent event or be impacted by a violent event or a really tragic event. And sometimes your role is just being there for them as well. So there's a number of therapeutic interventions um, that can be helpful when doing therapy in this type of setting. Um, definitely trauma-informed therapies if they're clinically indicated and there's the space allowable to do that. IFS is one that comes up, so that's internal family systems. And basically the concept of IFS is that we're all human, we all have protected parts, we all have wounded parts of us ourselves. All of our parts are okay, are meant to be there. They serve a point. And we also have our core self, um, which is can't be damaged and kind of empowerment that we can heal ourselves. I will have links to a lot of these therapeutic interventions if you want to do some further learning about them on your own. Dialectical behavioral therapy comes up a lot. Definitely as people are navigating relational issues, interpersonal conflict, self challenges with distress tolerance and emotional regulation. Schema therapy is an approach that draws from cognitive behavioral therapy, attachment theory, psychodynamic theories, and emotion focused therapies. Really is used a lot with individuals with personality disorders and narcissism. Medication management comes up a lot. Checking in with clients about their medications, if they're taking their medications, if they're misusing their medications. Sometimes also that could include not only psychiatric medications, but medical assistant treatment. If someone's incarcerated, things, and also to not incarcerated could be things like journaling, mindfulness, finding meaning in each day, focusing on the basics of what we need to take care of ourselves. So physically, emotionally, psychologically, spiritually. Sometimes issues of sleep and sleep hygiene come up. Codependency and narcissism in relationships. And I think, like I said before, prioritizing high risk cases, frequent contacts, and producing solutions for their care. So if there needs to be some collaboration with the team to produce some sort of outcome for an individual with high needs, that requires the effort and the support in doing that to help that individual. Um, in forensic settings such as prisons and jails as well, there are also situations of one-on-one suicide checks. So that's somebody that is on a constant observation due to risk of suicide. Sometimes that also includes step downs. And so high risk monitoring becomes a big role in those settings. So sometimes that could be like a one-to-one suicide check becomes a 15-minute check. So that means a staff member is checking in with that individual every 15 minutes. Also, as mentioned before, really collaborating with the people that you're working with to not only advocate, but address any safety issues. In addition, it's really important to advocate when care is not safe and is inhumane in a setting, or if it's just really not working. Don't be afraid to speak up. Definitely, social workers have done this. I'll mention Justina and Rikers recently in New York City. So definitely that is a role that we have. And don't be afraid to do that because it's really necessary for people to get the support and the care that they need. So that is the kind of the end in terms of my part in discussing. I really would like to kind of leave things open for everyone else to add any information that they feel would be helpful, ask any questions. I added some links here to job kind of related links. I also added some links about policy and advocacy in the mental health area. And then I also added some links in terms of some of the clinical training and modalities I briefly discussed, and also professional organizations. And as Amelia discussed, this PowerPoint will go out following the chapter chat tonight. And then the final page, I just gave my contact information. Certainly anyone on this chapter chat tonight is welcome to reach out to me, ask any questions, share any information. I always love learning. So if that happens as well, great. I would love that. And also my cell phone number is provided. And I thank everybody for joining.
Thank you, Heather. All right, we have a bunch of comments coming in now in the chat box saying what a great presentation and thank you for your time. But oops, I know we do have a few questions. One person is asking if you could, okay, bunch is coming in. What about opportunities to do forensic reports privately? Would you like the person to expand on that question?
Yeah, so I think that this does happen in certain settings. What I will say is I don't personally have a lot of experience with it. But certainly there are social workers or mental health counselors or even psychologists that may do forensic evaluations in a private practice or in a private setting. Sometimes those can be related to things like competency, and other areas. I would say that there is a link that I know of. I'm forgetting it off the top of my head. But there is, I think, a national training in terms of forensic evaluation. So for that question, I can definitely try to find that link and then get that out to anybody that would like it. Or if there's a way, Amelia, that we can send that around to everybody. I also could probably give some names of individuals that I've seen that do private forensic related evaluations. Sometimes I would say in community mental health, sometimes you get requests to do psychiatric I guess, biopsychosocial evaluations for family court related issues. So I do have some experience with that. But certainly I'm happy to give some extra information that is not here right now in the presentation. I'll add that in.
Thank you so much. There's a bunch of questions, so I'm going to kind of go right through. How successful do you feel therapy is for people suffering from narcissistic and antisocial personality disorders? Is group therapy recommended for these diagnoses?
Um, I think just personal perspective, I don't know that group is typically recommended. I think actually some of what I have heard from just mentors over the years is that sometimes groups, and especially like correctional settings, aren't always utilized. Sometimes they are in smaller facilities. I think obviously with like an antisocial narcissism, you might see some shifts in group dynamics when that happens. Doesn't mean there's not ever groups in any facility. I would say that really, in terms of success for somebody with traits of narcissism or antisocial traits on those continuums, really depends on accountability. Is there accountability there for their actions? Understanding of the fact that they carry narcissistic traits. If there's not accountability and awareness for this, then typically there will not be a high success rate. Sometimes there is, though, really. So there's a book that talks about this a little bit. It's called Stop Walking on Eggshells. It is really geared towards individuals that are living with, or, you know, close to somebody that has a borderline personality disorder. But one of the things they talk about in that book is this idea of an unconventional borderline and a conventional borderline, because oftentimes a BPD diagnosis also falls with some traits of narcissism, which are developed from childhood trauma, essentially. But the idea of conventional BPD is usually somebody that likely possesses BPD and narcissism traits, and they end up cycling through the mental health system. Oftentimes, a lot of suicide attempts, oftentimes, a lot of high risk behaviors, really struggling with depression. I would say unconventional or the conventional BPD can be successful, can go on to live pretty successful lives. And there also are some books and some literature and some like self-report of individuals that have talked about this in their own stories. Unconventional usually are those with narcissism and symptoms of BPD, which aren't really having, they don't really have that accountability piece. So oftentimes they don't end up in the mental health system learning about what they're going through. And oftentimes things just kind of spiral and keep spiraling. So that was a little bit of a long tangent, but that is how I would answer that question.
Very thorough. I want to ask for Tori, do you have any advice for someone who has a BS in criminal justice and is enrolled in their MSW? What steps should be made to go down the forensic social work track?
I would say if you are currently working and kind of moving in that direction of the MSW, whatever program you're in, take a look at where there are opportunities for classes to learn about law, to learn about juvenile justice, to learn about criminal justice, to learn about diagnosis, to learn about crisis assessment. Certainly some trauma-informed interventions would be helpful. Really having strong clinical skills, strong engagement skills, I think are important. And then also too, if you're going into your MSW program, you will do internship. So I would say advocate for yourself for an internship that is within a forensic setting, an area that interests you. Say you want to try out working in a jail or a prison, if that's available through your MSW program, try to do that. Or could be public defender, could be parole or probation, could be community mental health. But really have those conversations with your advisors in graduate school. Also have those conversations with your supervisor, your clinical supervisor, when you are in your internship. I think one thing I also did when I was in my undergrad program is I happened to hop on a Families Anonymous meeting that met at the local jail, where I did my undergrad program. So sometimes there might be kind of those volunteer type activities which can help build awareness and more knowledge in the field.
Thank you. The question of, are there any tips or phrases that are essential for documentation in the forensic social work setting?
So definitely, um, templates are good. If you can really have like templates, that can be really helpful. So it could be, I mean, I'm not sometimes good off the top of my head in terms of thinking like a phrase, so to say. But a lot of times, if you're doing documentation or a note, you're going to do, a mental status exam. So if you can somehow have a template of a mental status exam, which looks at, hey, are you alert and oriented? What's your mood? How's your eye contact? Different things like that. Are you suicidal, not suicidal? Those things are important. I think also, too, briefly discussing the intervention that you did. And also, too, you can kind of say, client discussed this issue today, whatever the issue is, very briefly. And then you can say intervention, say DBT utilized, follow up in 2 weeks, or however, whenever you're going to do that follow up with the person. But certainly there are, I think I would definitely, if you can get your hand on some templates, or if you have questions about that, certainly I'm happy to talk to you as well.
I just want to say that there is someone that put in the resource of the National Association for Public Defense also provides training and resources for forensic social workers. I wanted to call out that resource. They have a lot of people saying that they appreciate this, and as other forensic social workers or social workers working in these settings, it can be hard to foster relationships or connect with other social workers that are in these settings, and so they really appreciate this conversation. Do you have any tips or recommendations for building relationships with non-social work coworkers, especially in correctional institutions?
Yeah, definitely. I mean, I think that really smiling, saying hi to people, never underestimate just like very simple things like that. If you're going to check in with a client in a certain pod of the facility and there's a officer working, ask them how their day is going, ask them what their plans are for the weekend. I think over time those relationships start to build as you are, um, you know, just inquiring about someone's well-being. And they appreciate that. They appreciate you. I know sometimes, um, and I've seen this with police especially, they like to play pranks on each other. So if you can have a sense of humor, sometimes you'll probably get wrapped into the pranks. I have personally myself. so so I think just you know, being simple, being kind, um, and just like we do our clients, treat them like people. We're all human, and it's nice to know, especially in a stressful setting like corrections for sure, that somebody's brings a kind of light to things.
Thank you. Um, the question of how do I get into this field? I know of several law enforcement agencies that are supposed to be hiring for social workers, but they don't act on it because it seems they do not want social workers or civilians in their space. So I think essentially how do folks break into this area?
Right. So I think it also depends on like, you know, where you live. I think like that could be different. Like geography can definitely impact this. So sometimes, and I might have said this earlier in the presentation, but sometimes like community mental health agencies have contracts with um jails or prisons, or um, sometimes it's private agencies. So I have some links of some private agencies that, um, you know, also touch into jails and prisons. I think for police social work, sometimes there isn't, depending on the police department, sometimes there's not funding for a mental health professional. Sometimes it's not something that's come up or has been discussed between mental health agencies and law enforcement. Sometimes it's a cultural thing. Sometimes it's, um, just that it hasn't been developed. So, I think those types of things are newer initiatives, but also too, I would consider like trying to figure out like, hey, do these things exist in this setting? And if it doesn't, and it's something you want to explore, try to go where it is explored. Also, the link that I included on Connecticut's social work and law enforcement program would be good to check out, because they may have pointers too in terms of how do I kind of break into this field. Certainly, I won't lie that you know, sometimes you have to get through some hurdles with, law enforcement. Sometimes they're not always welcoming of mental health coming in the picture. Sometimes they have an attitude of, I do this all the time anyway. Why do I need this person around? So I think also too, like really educating on the value that you bring, and knowing the value that you bring so that if you witness or face some of those comments, doesn't hit as hard. Because I think we know at the end of the day what skills we have and what we're qualified to do.
Thank you. Diane recommends folks check with the New York City Probation Department. I also got a message that says, I initially was very interested in forensic social work and had an internship at a prison. I noticed that it became too much for me and eventually had to leave my internship. I felt that I was taking too much home and I felt a lot of conflict in my heart, and I felt like there was somewhat a conflict of interest. Do you have any skills or tips or skills that you think people need to have in order to go into this line of work and in order to keep this work and life separate from each other?
Yeah, definitely. So, um, as I said before, if you need support, therapeutic support, make sure you're getting it. There isn't any shame in social workers getting support for themselves. I have myself. So I think that, yeah, burnout is very real. And I think that if you're definitely, we have to make that effort to separate work from home. So that means going into work. I think one thing I do a lot of times when I'm working is I just shut off my phone. I'm shutting off my phone. So when I'm at work, I'm focusing at work. And when I'm home, anything to do with work, I'm like, it'll wait till tomorrow. Um, Obviously, I think sometimes you may be faced, whether it's, maybe agency culture, or maybe say you work for an organization that has an on-call system, or there's kind of a culture of talking a lot after work. I would say set clear boundaries with that too. Tell your supervisor, I'm not doing this. I can't do this. I don't have like it's too much for one person. So being able to be honest about those things, and it doesn't mean that you're weak or anything like that. Um, and I think also too, sometimes like if we are reflecting on a client case, um, we might be talking to a colleague about it and it goes after work hours. So I would say as much as you can limit those types of things as well. Um, and give yourself like that time. Say, okay, when I go home, I'm only going to focus on this for 10 minutes and then I'm going to go for a walk or I'm going to um, watch TV, something funny, So I think just thinking about what those boundaries would look like for you. But those are some kind of initial tips I would give.
Thank you. Uh, Doris asks, do you think that people with disabilities can work in a jail or prison? Doris, if you want to expand on that, please feel free. Uh, but I wanted to make sure I asked everyone's questions. Heather, do you have any responses or questions for Doris and what she means by that?
Yeah, I guess I would want to know a little bit more about like whether this would be a physical disability, emotional disability. I think either way, I would say yes. Um, and yeah.
Oh yeah. I was just kind of curious because I'm here. I'm actually in California, and it was like such a negative thing because I'm a person with disabilities, and so it was such a negative thing in the county jails that I had a disability, um, and so I just wanted to get a different perspective on it.
Mm-hmm. Yeah, no, and I'm really sorry that you went through that. And it's not okay on any circumstance. It's also not legal,
Yeah.
So I think that certainly there are settings where you wouldn't face that. I
Mhm.
think that um there are settings, unfortunately, where um, people do not uh, have that respect and dignity. Um,
Mhm.
and I would say that, um, unfortunately, you know, it's like finding the right place. I think jobs are important, right? Salaries are important. But it's also important how we're treated as individuals and as human beings. So it's not worth it to stay in a role that you are being harmed in some way. Um, and it's even if it pays well, because it's at the expense of your health and your well being.
Yeah, yeah, for sure. Thank you for definitely affirming me. Yeah, it was exactly what you're saying. But I still have like that spirit, to and energy and passion to continue just moving forward with what it is I am passionate about. So, um, but yeah, I was just curious.
Yeah, yeah. What are some of your passions, Doris?
Oh, well, over here in LA, California, downtown LA. I don't know if you guys
Mhm.
know anything about that, but it's like it's a lot of homelessness, right? So I've been working in homelessness for a long time, in that field, helping folks get housing and things like that. But just slowly I've made my way over more to the mental health side. And
Okay.
so, yeah, and it's very different from what I was doing before, but it continues to be something like, because even the place where I work right now, which is a community clinic, in downtown LA that serves like mostly unhoused folks, and folks who just recently got released, right, from jail or prison, federal prison, things like that. We work with
Mhm.
them and transitioning them in to society. And so all of it is just, connected to each other, and my background in housing and vouchers and all that kind of stuff seems to be very helpful for a lot of folks who are looking for that stability.
Right,
Um,
right. Yeah.
it's just like extra comfort and support for them. So
No, very, very good. And I think it's very much needed. Definitely. Thank you.
I have one last question, Heather, that I want to make sure we get in, from Tara, who is an MSW student interning at a pre-release center. They lost their only therapist recently, and she's wondering if you have any suggestions about finding resources for their residents. What might she be able to do as a first year student to help out? She's in a semi-rural part of Montana, so this can be tricky.
Okay. Um, so, um, and it sounds like the um therapist, okay, so the therapist is gone. And so you're kind of maybe the only one on board right now. Um, I would think, definitely if it is looking at, pre-release, into the community, being aware of what resources are locally to where you are in Montana. Um, because those might be things that you can help people get connected to, as you're kind of building on your clinical skills as well. Not that you don't have them. I certainly think continue to use those skills that you've developed in your program. I think also too, sometimes early on worksheets help a lot. So definitely using resources that have like certain worksheets and different types of skills, like like DBT or some so IFS worksheets, different things like that to give some clients some education. Um, but I think that connectivity piece is really important. So just making sure that you're aware you can make calls as needed, and continue to support those individuals. I think also too, because they're losing their social worker, they may be navigating that emotionally as well. So being able to talk with them about how that's impacting them, and empathize and really validate with them as well.
Awesome. Just thank you so much, Heather. There's a bunch of comments in here, just people saying how grateful they are for this presentation, actionable presentation. That's always a great thing to hear. Um, just so much gratitude in the chat. So thank you, Heather. Thank you, Martha, for connecting us with Heather and making this available through the new Northeast Division. This recording will go out to everyone that registered. I saw we got up to about 120 here, and I'll send it out to everyone that attended, everyone that registered, both the slides as well as the recording. And someone just said, oh my goodness, I missed the presentation. Is there any way to access the slides? Yes, John, you'll get both the slides and the recording. So thank you so much, Heather. Thank you, Martha. Thank you everyone for joining us. And I hope you have a great rest of your week. Bye-bye.
Thank you.